My name is Alex Burns. I'm the fellow with WMed in Kalamazoo, and I'm going to talk about anxiety and pain perception today. Um, I had a couple patients, pretty challenging patients over the last couple months, and I just wanted to bring those cases to light since they were a challenge for me to figure out. That's right. Is it?
You can use, you want the mouse back, or you can,
Oh, there we
now
go.
you can see what you're doing.
I have no disclosures because I am just a fellow. These are my learning objectives. I want to talk about a couple of the cases that I had and then kind of go into neurobiology of pain, biopsychosocial pain model, how pain and anxiety are related. Some interesting things that research has found about the sex differences in pain perception, and then some methods of managing pain related, especially to anxiety. So the first case, this was an 81-year-old female that came into the hospital for recurrent cellulitis. She had a history of AFib, PVD, anxiety, depression. Palliative care was consulted for pain management. So she had been on morphine twice a day for the past 20 years for chronic pain. She wasn't able to really tell me a whole lot about her pain history, which would have been helpful, but I understand that sometimes patients are just on medications and don't really know why. She was unable to really provide me a good description of where her pain was, describing it for me. She just stated she thinks it's in her both of her legs. She did say she's been dealing with cellulitis on and off for the past 6 weeks and has been hospitalized multiple times for an infection, occasionally complicated by sepsis. So when I saw her, she reported severe pain in both of her legs, which had worsened over the past few weeks due to her cellulitis. So her primary care, who had been managing her chronic pain medications, had recently started her on tramadol in addition to her morphine, but she did not think that there was any relief with that tramadol. So initially, we started the patient on her home dose of morphine, but 3 times a day instead of the twice a day. And then I scheduled Tylenol and gabapentin. She had been on gabapentin at some point in the past, but she was not able to tell me if she was currently on it or not. And when she was trying to describe the pain to me, some of it sounded neuropathic. So that's why we added that as well. So, and this consult was on a Friday. So I saw her on Friday. And then I did not work the weekend. So the next time I was going to see her would be on Monday. So I checked in on her later that evening. She said her pain was a little bit better than when she initially came in. And then one of my colleagues saw her over the weekend. Saturday, she seemed okay. She still had severe pain, but appeared more comfortable. And then I'm not quite sure the timeline of when things happened, but sometime during the weekend, I think during the night, the patient was suddenly made comfort care. And our palliative team had no idea that this was happening. So she was started on a morphine drip. So we came in on Monday and saw that she was on a morphine drip, completely somnolent. We didn't know what had been going on with her. Documentation wasn't very clear. And there was concern that the patient was in an acute pain crisis and didn't fully understand what comfort care measures meant. So the palliative team and I were very upset about how this transpired, because talking to the patient, it did not seem she was on that path at all. Like I mentioned, she was extremely lethargic on that drip, but family concerned her pain was still not managed. So she didn't have children, and her spouse was not technically her DPOA. At least we did clarify that beforehand. She had 3 people she wanted to be MDPOA. One of them was at bedside and kind of given us a little bit of history. So we had discussions with the spouse was present in the room, but we had discussions with the DPOA that was in the room as the patient was too lethargic to really answer questions. We had a lot of discussions, and after the first couple discussions, we're like, no, we don't want hospice. We don't want comfort care. I'm like, okay, well, let's stop that because I think we can manage this on our own. We just need to get antibiotics for the infection and good pain control. And so we were in the process of weaning down the morphine drip, and the patient started waking up and feeling a little bit better. But once the morphine was, once we got her off the morphine drip, then she started to continue of that severe ongoing pain. And she would usually rate it a 9 out of 10. So we felt that, so initially we thought the oral regimen that we had was going to be effective because that first day she's like, oh, it's starting to feel a little bit better. But after being on the morphine drip, coming off of it, and then still complaining of this 9 out of 10 severe pain that she couldn't really tell us a whole lot about, we decided that we should do some IV medications. We actually discussed ketamine since she had been on the morphine for so many years. We thought, let's just try something to kind of reset her pathways and see if that worked. And patient and family was in agreement with that. So we had her on the ketamine for a few days. I think it was 4 days. I went and saw her every day. These visits ended up being like 40, 45 minutes each. She was unable to tell me if the ketamine was working. So that was a challenge because I felt that, especially on day 2, we should have had some sort of relief or something. She kept rating the pain as 9 out of 10, couldn't really describe it for me. So we were trying to really figure out what's going on. She did appear comfortable despite saying she had a 9 out of 10 pain. She was always pleasant and conversational to me. But then, so she does have a history of PVD, like I mentioned before, and she did have chronic on top of her chronic lower extremity wounds on top of her acute cellulitis. The cellulitis was beginning to resolve with the antibiotic use. The redness and swelling was significantly decreasing. But she began to refuse her dressing changes because of 9 out of 10 intense pain that she had a hard time talking to us about. We had a lot of discussions actually with wound care too, because they're like, well, how are we going to manage this? And so we're like, okay, let's try and adjust her regimen to see if we can give her some like the pre-care medications. But that didn't really work either. There were some things that they could do. I don't know all the wound care stuff that they had, but they started just using like a topical to keep it clean. But she was refusing to lift up her legs and have them check underneath. So it was very challenging. And the one couple glimpses that the wound care team got of her, the bottom of her legs, they needed to be addressed. So that was kind of another complication on top of us not being able to manage her pain. So I didn't put everything that we tried, but we tried about a lot of different stuff. We tried some IV morphine with some PRN dosing. We scheduled some of that. And then her pre-care PRN dosing. And then we scheduled Tylenol. And then at some point I started lorazepam because I felt that some of this was related to anxiety based on what nursing and wound care was telling me, that she would scream before they even touched her legs. So I'm like, okay, so there's some anticipatory problems related to her wound care. And then we also increased her gabapentin. So, but despite all the changes in the dosing and timing, she continued to report a 9 out of 10 pain with no relief. And I was not really sure because I felt like we had a pretty good regimen that I've used for other patients that I've had good results with. And then, like I mentioned before, wound care also became a challenge. She started declining it, but then she was frustrated that her wounds weren't being taken care of. The husband was in the room saying, well, why aren't we taking care of her wounds? I'm like, well, she won't let us touch them, and we're trying to help her figure this out. But each time I saw her, at least, she was very pleasant, very conversational. She appeared comfortable. And we were continually talking about her pain regimen and wound care and trying to readdress that. And she would As much as this was challenging, she would want our team to come up and talk to her about things throughout the day. So I felt that even though I didn't feel like I was getting anywhere, she felt comfortable talking to us and wanted our palliative care team to come up and address all of her care with her, which would be challenging. So she was, I think, there 21 or 22 days. And during that whole time, she refused to get out of bed. She wouldn't even get up into the chair. So that was a challenge too. And I had a couple conversations that you can't just sit in bed. We're concerned about wounds on your bottom. There were a few times where, due to her anticipating the pain, that she wouldn't even let them clean up her soiled bed sheets. And then, so like I said, I saw her every day, sometimes multiple times a day, with very long conversations regarding her goals and wishes. Because I wanted to make sure, because we were talking, if you can't get up and move, you're going to be very, very debilitated. And so you would have to likely go to a rehab facility afterwards. How do you feel about that? And they're not going to be as attentive as in the hospital. And I think that was some of her anxiety as well. So by this time, after a lot of these conversations have been had, her cellulitis was resolved from a clinical standpoint. She had finished her course of antibiotics. So medically, she was kind of just sitting here waiting for pain control and PT/OT to work with her, which she was refusing a lot. So my attending and I were like, okay, so there's something else going on, because the pain meds that she's been on and everything we've done should have been helping her. So we started discussing that, okay, we think her baseline anxiety is playing a huge role in this. So we're trying to figure out some ways that we can help her cope, because with what we had her on, I didn't feel that she should still be a 9 out of 10 pain, but appearing comfortable. So we talked about meditation with her, and we delicately broached the topic that we think your anxiety, is contributing to this. And in the subsequent days, we would kind of continue to talk about that. And I think she did sort of understand that. We did talk about meditation. She didn't really have any particular spiritual or religious things that she was really into. So prayer wasn't really an option, but we talked about meditation. We talked about, thinking about putting yourself in a situation that makes you happy. Where do you want to be? Where's it kind of like your happy place? She tried that, from what I can tell, for a couple days, and we did seem to get somewhere with that. But again, she was refusing wound care, dressing changes, and then getting upset about it, getting anxious. We kept trying to adjust pain meds and tweaking it, and it didn't seem to work as well either. We continued to talk about goals, and we talked kind of about next steps, and she really didn't want to go to rehab. And we're like, well, we brought up hospice at one point, and we had quite a few conversations with her about that as well. So actually, the last few days before she was discharged, when I went in there, I didn't even talk about her pain at all. We strictly focused on, what do you want to do to get out of the hospital? And we kind of broached it as, I feel that you will do so much better once you get out of the hospital. You've been sitting here in this bed, in this room for so many days. And I don't think it's really good for your mental health right now. And so once we started talking about what are your next steps and getting a plan going, and she eventually chose to go home with hospice after multiple conversations, trying to make sure that she fully understood what a hospice was. And she did. She would repeat back to us. Her mood significantly improved, her pain improved, and she let wound care start doing some stuff on her. So I saw her again on Friday, and we addressed, okay, home with hospice. Let's see how the weekend goes. And then I saw her on Monday, and she's like, I had the best weekend ever. Best weekend with very little pain. And by this time, we had actually started decreasing her pain medication. So she was on less pain medication and had the best weekend. And then she went home with hospice, and that day she was the happiest I had seen her. So this was a very challenging case because I didn't feel like I made any headway with her consistent severe pain. But I felt like once we started addressing her anxiety and helping her have a game plan, that is what changed her perspective on everything. And for the whole time, she was extremely pleasant and conversational with me. She told me she enjoyed when I came up and chatted with her. But I didn't feel like I made a difference, but I'm hoping that I did at the very end because we got her home, which is where she wanted to be with her support. So anxiety in this case definitely contributed to that. Case number 2, and then this was my next month. 79-year-old female admitted for intractable abdominal pain and nausea secondary to metastatic pancreatic cancer. Past medical history, AFib with multiple bowel restrictions resulting in a short gut syndrome due to an SMA emboli 5 years ago, and a history of anxiety and depression. So we were consulted for pain management. This is sad. She was recently diagnosed 3 months prior, had not gotten into oncology to discuss potential treatment options. I think she just hadn't been feeling good and it was hard for her to get places, but her pain was so intense she came into the hospital. So we initially started her on oxycodone every 4 hours, scheduled Tylenol and Dilaudid as needed for pain, in addition to Zofran and Compazine and simethicone. So this was all complicated by intense nausea related to her mass. And so the nausea was playing on the pain as well. So initially when I saw her, she was sitting up in bed, rocking back and forth. You could tell she was clearly in discomfort. So she still continued to report 10 out of 10 pain despite her current regimen, but also had a difficult time telling me where her pain was and unable to state if her nausea was improved on the medications that we had tried. That was the first day. The next day, she did appear more comfortable. And her husband, who was at bedside every single day, I think I only missed him once because he stepped out to get lunch. He was there all the time. He said, I think she's doing better. He said she slept a little bit. She's not moaning continuously or rocking in her chair. But so she did appear more comfortable, and she did tell me the second day that there was improvement in her pain and nausea. We did discuss, because she still at this time wanted to pursue, discussing with oncology about potential treatment options. We're like, okay, based on your location and the persistence of your pain, we're like, maybe a block would be a good idea, because the attending I was with, she's like, I've had really good results with patients with pancreatic cancer and getting celiac blocks. So we discussed that, and the patient was agreeable to that. So she ended up getting the block, but then we went back in the room the next day and she's like, well, I don't know if it helped. I'm like, okay. But she did look more comfortable, and her husband continued to express that she looked more comfortable. Again, this was another very difficult symptom management case. Patient had a very difficult time telling me what her pain was, if it was better on any of the medications that we tried, if her nausea was improved. It was really hard to know what was effective, because she's like, well, I don't know what they gave me. Nothing seems to work. She still complained of her 10 out of 10 pain. So she had tried Oxy, and then she's like, well, I don't want this. Let's try morphine. So I'm like, okay, we'll try morphine and see if that helps. She couldn't give any reasoning for this change. She's just like, well, I want morphine now. I'm like, okay. And it was reasonable to try something else. She has 2 adopted children who were both present at different times throughout the hospitalization, and they gave us some history surrounding her behavior. They both said she suffered from anxiety and would refuse to discuss serious issues. So when she was diagnosed with cancer, she didn't want to talk to him about it, which I understand. It's a hard topic to have, but she was very adamant. Like, she did not want to discuss anything, even though we're in the hospital trying to figure out next steps. Do you want to talk to oncology? Do you want comfort care? Do you want hospice? What do you want? And she refused to talk about any of that too. And her husband and her children were trying to engage us. And we said, well, can we step out? Oh, no, I want everyone to be in the room, but I don't want any questions asked. So she wanted to be part of the discussion, but she didn't let discussion take place. So that was another added layer. And I think this was all related to her anxiety, and her children also said she's been like this her whole life, very, very controlling, unwilling to give up anything. So we had lots of different conversations again about trying to have conversation about goals of care. This particular patient would often interrupt or halt the conversations. So we'd be having a conversation in the middle. She's like, oh, I need a drink. So then it would take 5 minutes to get the drink. And then she would have a coughing fit. So we'd have to wait for that. A few days later, I just started ignoring those because it was derailing the conversation. And the children were like, we need answers, Mom. Stop. Let's see. Family did seem to be enabling these behaviors a little bit. But near the end of the hospitalization, they're like, no, we need answers. And then she started making statements like she just wanted to die. And we had heard from the daughter that her mom, when faced with other serious medical things like a broken arm in the past, had made similar statements. So they weren't quite sure how to take this. This was a more serious diagnosis than a broken arm. So, and she continued to state that she was nauseous and pain. Nothing seemed to work. So after lots of conversations, she elected for hospice care. And we ended up sending her to Rose Arbor on a drip. Again, I felt like we weren't making headway, but the family really wanted us, again, the palliative team in there for every single conversation. We also went up into that room multiple times. And just before she got transferred, the husband's like, I want to see the palliative care team. I want to make sure that they're okay with her being pre-medicated and she's going to be comfortable on the ride. So we went up. And her husband was so happy to see us. He's like, I would have been so upset if I missed you guys. He's like, are you okay with what the plan is for sending her to Rose Arbor? Is she going to be comfortable? We're like, yes. We told the nurse this is what she needs. So family felt that she was taken care of, except it was a very, very challenging case for me as well. So keep these two cases in mind as we go throughout. So I hadn't thought about this in so long since med school. But brief introduction to neurobiology of pain. So these peripheral nociception begins at the nerve terminals in response to that noxious stimuli. Various free nerve endings that respond to a wide range of stimuli, cold, heat, toxins, mechanicals. The A, delta, and C fibers are two widely distributed types of pain fibers that play a pivotal role in transmission of pain towards the central nervous system. The A delta fibers are faster and transmit sharp, intense sensations, and the C fibers are slower and transmit a more burning neuropathy type sensation, as well as continued pain even after the stimulus is removed. There are many different types of tracks that we all had to learn in med school. We're not going to go into detail on those because I can. But action potential generation occurs in response to that receptor binding, and the action potential is either up or down regulated by other receptors. And then amplification occurs with regenerative sodium channels and inhibition through potassium. And then cell bodies in the dorsal root ganglia transmit signals to the CNS. This is the one tract I'll mention. The spinal thalamic tracts as they ascend to the somatosensory cortex. And I like this image because it's relatively simple and it just reset my brain. I had to really go back to med school for this one. And then this is so I read quite a few articles in preparing for this lecture, and I had never heard of like the pain matrix. So, and understand the pain matrix in the brain is needed in order to fully understand the experimental observations that people have done in pain perception. So it's the complex interplay of various brain regions as they're activated simultaneously to communicate and synthesize information to create the subjective experience of pain. And the article that I was reading said the pain matrix model describes 3 unique matrices: the primary, secondary, and tertiary. So the primary matrix relates to pain and its location. The secondary matrix relates to attention and the effect. So the where and when components of pain perception. And then the tertiary matrix relates to cognitive meaning. So this can affect pain response in the setting of anxiety and different behaviors reacting to pain. So this is where we put like our cognitive thinking part on it. And this is where anxiety, depression, some of those mental health disorders can take pain to kind of to a different level. So the matrices that I discussed on the previous slide, like I mentioned, can be linked to how anxiety affects the pain perception. Specifically within the tertiary matrix, which adds cognition to the complex equation, producing the subjective interpretation of the stimuli. The tertiary matrix uses memory to place stimuli in the context. So this is the area where people can place negative emotions to pain perception. Anxiety, which we saw in the first 2 cases, was the biggest component for those women, is one such emotion. And this depends on the person's cognitive state. So a person who is already anxious is already primed to place negative emotions or perception on a particular pain stimulus. So the cognitive state has a significant impact on how they form their pain response. And the articles that I was reading did mention that if you have like the people that are positive, that say, I'm gonna, get through this, I can do this, they typically have a much better result as opposed to someone who places a negative impact, which makes sense. So there's so many other emotions, but I'm focusing on anxiety because that is what my 2 patients definitely exhibited. And then there's this nocebo effect, which is an increased pain response to an inert stimulus, and it's mediated by CCK receptors. So if you have a CCK antagonist, it can decrease the hyperalgesia. And then the articles also mention the amygdala, which we know is related to memory, which brings back the tertiary matrix, uses memory. So all those play a role in anxiety and then respond with hyperalgesia, which makes sense in my patient cases, because I do believe that's what we saw. And I had to go back to this, the biocycle social pain model. So the model of pain is a multidimensional approach that attempts to reconcile the dynamic integration between the various aspects of the human experience, not only biological, but psychological, social, and spiritual forces that surround us and make us who we are. So this model has many practical applications within the field of medicine, notably within the field of pain management and palliative care, because we treat the person as a whole. It acknowledges the many interrelated facets in an attempt to provide more holistic patient care. And this is what we do in palliative care every day. We take each aspect of the patient in order to try to come up with the best plan and help the patient make the best choices for them. But this broke it down for me and made me think, oh yeah, this is what we do every day. And now I want to be more particular on focusing on each of those aspects. General variables that affect pain include distress, trauma, and interpersonal factors, which I saw with my patients as well. And then pain-specific psychosocial variables that I was reading include catastrophizing, which I hadn't ever heard that word in that context before, expectations, pain-related coping, which this the expectations part really got to me, because we always tell our patients, well, don't ever expect your pain to be 0. We want your pain to be a manageable level. because we want to set that expectation so they're not thinking, oh, when I get this pain medication, I'm going to be no pain at all. So I thought that was really interesting because we do talk about that a lot in palliative care. And I do feel that my patients were, this word is really hard for me to say, catastrophizing the situation. They were putting so many negative emotions into their perceived pain that they were, as a result, my pain medications were not working for them. So this is just an example. I took case one. Looking at the biological factors, she had recently diagnosed cancer. That's a serious diagnosis. There's a lot of thought and emotions and what ifs, what's going to happen that goes into that. Socially, we looked at her relationship with her husband and children. I do think a lot of her anxiety was related to she didn't have control over the situation. She took it out on her husband and children, who are her support, and they were very gracious and very loving towards her, despite her being angry at them most of the time. Psychologically, she has that history of anxiety, control. She has the feeling of loss of control, which I definitely was in her and was playing a role. She just got diagnosed with cancer. She's like, she didn't even know how to process that. In her case, she had no particular spiritual beliefs that we're able to fall back on, but a lot of other patients I have met, they really rely on their religion, and that can help them throughout the course. And then I just want to say one thing about the spiritual, and because it's important to me, but it really, the spiritual aspect really affects how we view the purpose and potential higher meaning of pain and suffering. Everyone views suffering and pain differently, and some people are more okay with the fact that they are suffering and they feel that it's something they need to experience, and other people put definitely a more negative approach on that. And the article, these articles are really interesting because I hadn't thought about it in this type of way, but pain and suffering. The sensation of pain can lead to suffering via the associated feelings of unpleasantness and catastrophizing. This combination leads to suffering that's often expressed as behaviors, which we all see: anger, frustration, anxiety, and depression. So catastrophizing is the tendency to magnify the threat value of the pain stimulus. People tend to feel helpless in the context of pain. Relative inability to inhibit pain-related thoughts, rumination on things. And these are amplified by deficient cognitive coping strategies. And then the combination leads to that suffering, and functional disability can actually also be manifested, especially in chronic pain. Because a couple of the articles I looked at were they had sections devoted just to chronic pain, which is what we see in this too. And I wonder if in my case one with the cellulitis and the PVD, if she had some of that functional disability related to her chronic pain, and we were trying to get, but she wasn't fully aware of that. And then I did think this was interesting as well. Acute exposure to cortisol has beneficial effects during a physiological event, but long-term exposure becomes maladaptive, leading to many problems. And then I've seen these maladaptive issues in patients that have chronic pain and elevations in cortisol as well, like cancer, obesity, metabolic syndrome, mental health. A lot of our patients tend to have that too. And then no meta-analyses have been performed to determine specific neural correlations between unpleasantness and suffering, but there's been multiple individual studies that evaluate healthy individuals and those suffering from chronic pain. These studies have identified several brain areas hypothesized to be indicated in this connection. And I'm not going to go into all of that research, but they've used imaging and measuring of different molecules to kind of determine that certain brain areas are involved. There were some really interesting images in the articles that I was reading that showed different parts of the brain light up when they were studying these. So there are two pathways that facilitate pain and suffering. The lateral pathway mediates painfulness, and the medial pathway mediates suffering. So by manipulating the attentional state, primarily alters the perceived intensity of the pain sensation without significantly altering the perceived unpleasantness. I know that's I had to read these a lot. And then by contrast, if you alter the mood, the perceived unpleasantness of the pain is altered. You can alter the perceived unpleasantness of the pain, but not altering the intensity. So suffering and painfulness can be modulated independently, which is very interesting. So these two pathways are separable, meaning one can have pain without suffering, and one can have suffering without pain. And suffering involves the cognitive, emotional, and autonomic components to it. And then there are sex differences in pain and suffering. Experimental studies investigating acute pain demonstrates that women actually have a lower pain threshold, pain tolerance, and perceive pain stimuli overall as more intense and unpleasant. And this was an interesting little blurb in the article I was reading. The more intense painful stimuli leads to an increased sympathetic autonomic response in women, resulting in more dramatic changes that can be seen, especially in the pupils and the skin. So women perceive it more intense in their brain, but then it's also manifested physiologically as well. It was also demonstrated that women are more likely to engage in catastrophizing of their pain, thus leading to a greater degree of suffering in response to the same stimuli. And I know both my cases were female, but I haven't seen cases of men that were as similar to the cases of the women that I used. I know men suffer from chronic pain, and I know they can catastrophize things, but I have not seen it this year in fellowship. Women experience more pain and thus more suffering than men, even with an equivalent painful stimuli. Chronic pain is 6 times more common in women than men, reflected by unequal sex distribution conditions like tension headaches, migraines, fibromyalgia, RA, chronic regional pain syndrome, among many others. And women also have twice the rate of anxiety and depression disorders than men. And I think all of us are aware of those statistics. So women tend to suffer more from painful stimuli than men, leading to increased fear, frustration, and anxiety in women when compared to men. Major and minor life events, such as cancer, in the case of my patient in case 2, are also experienced as more intense in women compared to men, leading to increased rates of anxiety and depression. And the article I was reading, they were saying, well, maybe this is why women utilize ERs or urgent cares more, because they suffer more. And so they're going in and they're anxious and fearful and frustrated trying to figure this out. And men don't have quite the same response that women do. More studies have demonstrated there are sex differences in volume and tissue density. So there's differences in actual brain tissue, but then there's also differences in emotions as well. So, so tissue and volume density differences in the amygdala, which we know is related to memory and emotions, the hippocampus and insula, as well as the medial, which is the pain and suffering pathway. So different analyses display not only differences between structures in the men and women's brains, but in functional capacity or functional connectivity and activity. So in the medial pathway, differential activation and connectivity mediates the different responses between men and women. seen genetically, hormonally, and immunologically. So the medial pathway in women tends to be activated more intensely during a painful stimuli than the lateral. And the medial is the suffering pathway. So this does lead to consideration to different treatment approaches for men and women, which I know we all have seen. But maybe women need a little bit more of the spiritual and psychological treatments rather than just pain medication. But it's really interesting that these studies found that there are structural differences in the brain tissue as well. So it's not all in women's heads. There is a structural component to it as well. But a lot of it is also the like emotion and cognitive experience that women place on it. So we're going to move on to some pharmacological methods for pain control. So based on the perception of pain and suffering mediated by the medial pathways, it'd be prudent to focus pain management and additional treatments on reducing overactivity of this pathway, because this is the suffering pathway that's expressed greater in women. We did discuss the lateral and medial pathways. They're important treatment targets, but there's a third pathway that some of the articles were looking at as well to be explored to help with potential treatment options, the descending inhibitory pathways. So this pathway may represent the percentage of time that the pain is present. So if we can control kind of these three pathways, maybe we can help our patient. So one of the articles I was looking at, to modulate the descending pathway, it's been proposed to treat with medications such as opioids, which we do, serotonin and noradrenaline uptake inhibitors such as duloxetine, attempting to decrease the amount of time the pain is present, and then modulating the medial pathway. They mentioned paracetamol specifically because there were studies that suggested that paracetamol not only reduces the physical pain, but also works on the medial suffering pathway. And they also mentioned NSAIDs seem to have effect on the medial pathway, decreasing the suffering component as well. And then modulation of the lateral pathway, which is the painfulness pathway, includes medications such as aspirin and gabapentin. And then modulation of the descending pathway can help rebalance the imbalance between the pain evoking and pain inhibitory pathways, which helps to decrease the amount of time the pain stimulus is present. So all three of these, by using these pharmacological methods, could try and help decrease the suffering and pain seen in those pathways. And this was an image I got from one of my articles kind of talking about all the pharmacological and non-pharmacological treatments that could be applied for these three particular pathways. And then some non-pharmacological, which I had to reach out in some of my cases that I saw. So the descending inhibitory pathway, they're recommending psychotherapy, some non-invasive brain stimuli, invasive neuromodulation, spinal cord stimulation, exercise. They talked about exercise a lot for that, and acupuncture. The medial or the suffering pathway, meditation, which we tried with case number 1, anterior cingulate implants for chronic pain, burst, spinal cord stimulation, and acupuncture. And then for the lateral or the painfulness pathway, somatosensory cortex stimulation, tonic spinal cord stimulation, yoga, and acupuncture. Some other methods, resilience-oriented interventions, which teach cognitive, problem-solving, and social skills to try and help kind of reorient and reframe your brain around chronic pain or the acute pain you're experiencing. Cognitive behavioral therapy, acceptance and commitment therapy, and PT and OT, which again goes with the yoga and the exercise. some specific distraction techniques, physical, like tactile stimulation, helping patients put their mind on something else. Knitting or sewing, trying to take their mind off that. Mentally, relaxation, deep breathing exercises, which deep breathing exercises we actually did discuss with my patient in case number 1 too. We talked about meditation, deep breathing, like when you feel the pain come on, let's just turn down the lights, take a breath, and try and focus. Prayer, which not in these 2 particular cases, but in many other cases, prayer works really well for people. And then environmentally, put on some music that really calms you. Put on like your favorite TV show. Is there a book or a peaceful setting that you can get into to help control this pain? And then I know the owner of this place and my brother worked there. It's the Institute for Contextual Health. It's a physical therapy office somewhere in the North Grand Rapids. And they specifically specialize in chronic pain syndromes. And they also work on these psychological things as well.
What was the name of it again?
The Institute for Contextual Health. And like I said, I know the owner and my brother worked there for a year and he said they do great work. People will travel 2 or 3 hours to get there. And he's seen cases where people can't walk and then they're there for like 6-7 months and they're coming out walking and they're super happy. And he said, the owner and his colleagues are great physical therapists, but they also really realize that a lot of it is psychological and social. And so they focus on those as well. And they have people on their team that focus on that too. So that's just something to think about, to refer people to in the Grand Rapids area. And those are my references. That's all I have for today. Does anyone have any questions? Do I stop sharing?
Yes, so go ahead and stop sharing. I can get it.
Well, I always have a lot of thoughts. So I wonder, like, going back to some of the gender-based studies in regards to pain, in how socially women are typically more allowed to express emotion or express pain, whereas men are socially taught to dismiss or kind of like shove down those expressions of pain and suffering. Right. But then we still see things like men in completion of suicide attempts are more likely than in women. And I kind of going back to that social construct of how we're allowed to express pain and suffering.
Yeah.
And also wondering about some of the selection bias with women and pain tolerance. So we're looking at women who have these diagnoses of fibromyalgia or chronic pain and have tried to come through the system to get an answer and seek a path to kind of alleviate their suffering, are women more likely to try to navigate the system for an answer? Whereas you think of like some of the stoic farmer, like, I'm never going to see the doctor. I'm not going to bring that up. I just go in and I get my lab work because my wife makes me,
Right.
So some of the selection bias of patients for these studies and socially, like the construct around pain. And it just goes back to that biopsychosocial model of pain and perception of pain and how we're allowed to talk about pain and the lengths we're willing to go to seek out methods of alleviating that pain. And are women more likely to try to advocate for themselves and pursue these kind of treatments versus men? So I kind of wonder about that. And it's just, I don't know, kind of a not just a talking point, but a way to think about like, how are we kind of approaching this and looking at it and in the research, it's not a clean cut sort of way of
not.
looking at things. And so just like keeping that in mind. Because I will say I have seen men who catastrophize
Okay.
things. I've also seen, men with fibromyalgia, with complex regional pain syndrome,
Mhm.
with hyperalgesia or like allodynia, but
Mhm.
that's kind of in my training and the type of patients that I see
Yeah,
from a rehab standpoint, like I'm seeing them come through the system with those complaints. So it's
Right.
like, again, that kind of selection bias and the kind of patients that are coming to us as well.
right.
But I will say also having done EMGs on lots of different kinds of people, who sits really well, those cute little old ladies do really well for me. But who seems to do the worst? The big tatted guys. So again, a little bit of like a
Yep.
bias there in some of the patients that I'm seeing, but it's kind of across the board.
Right.
Like everybody's individual kind of response to pain.
Right.
But I think, like you were saying about kind of the anxiety and anticipation around
Mhm.
some of these things, and then kind of being stuck in the hospital or like having some of these life-altering diagnoses, like a
Mhm.
new diagnosis of cancer, and haven't been able to see an oncologist yet. And there's a lot of uncertainty around that. But then also very real physical symptoms, like there is a physical reason for that pain, but how we kind of,
Navigate
yeah.
that.
And then I also kind of wondered about, there was a study that you had referenced about like a structural difference in kind of size and activation of some of these areas of the brain. And I, again, wonder if that's a little bit of nature and nurture, right? Like you exercise a muscle enough in the right way, like
Right.
it grows, like are we societally the way that we exercise those emotional muscles different? And is that leading to some
Right.
Are we
of that
strengthening
structural?
neural networks and?
Yeah.
others?
Mhm.
Yeah.
So, and then I had another thought, about the acetaminophen
Yeah.
and pain and anxiety. That was brought up in the neuropalliative uh conference. Who was it? It's our,
Was it Benzie who brought? it?
yes,
Okay.
yes, it was. And I wish I could remember more about what he was saying about that.
I don't recall that.
I recall it just enough where it was like
I
that line came up and I was like, oh yeah, that's
found it.
there was. But okay, so I will stop with my comments for right now.
No, but those are all good thoughts. And these are just
Right,
certain
like
articles. Like this is just trying to figure out, is there a structural component, not just this emotional cognitive, but like actually, like it was very interesting.
yeah, like how do we approach this to
Yeah.
help people navigate their perceptions of pain so they can be more functional in their life?
Exactly.
Right, and there are, like Cleveland Clinic has a chronic pain program, like Mary Free Bed has a
Okay.
chronic pain
Yeah.
program that utilizes both like physiatry and physical therapies as
Mhm.
well as pain psychology all
Mhm.
together as a system to kind of work through all those things. You're working
Yes.
through the physical and working on, functional deficits that you might have, but also your perception of pain and what are other ways like meditation and movement, like dancing alone has been shown to be as effective as some SSRIs for some people. Like some of those things
And
kind of
that-
help cope.
In that clinic you're talking about, you find there's a fairly equal number of men and women in it, or not necessarily.
I haven't looked at numbers,
Yeah.
so, but I've seen both men and women come to clinic like that.
But yeah, you have a different perspective because your rehab background.
Yeah, uh-huh.
Yep.
And I'm curious if you came across anything about locus of control through all of this. I see a lot like the Mary Free Bed
Yeah.
Pain Clinic. It can work for people who perceive they have control over this.
Mhm, mhm.
And
They didn't mention that, but some of their recommendations, like the CBT, some of that to me seems like that would be part of it too, trying to figure out, I guess. And that one part where it's like the people that have a more positive experience
Mhm.
or a positive attitude do better. And it could be that like feeling, I might not have all the control, but I have control over how I approach this.
Mhm.
And so maybe that was some of it. They didn't mention those words specifically in the articles that I read.
But yeah, that like placebo versus nocebo, like if you go in thinking like, okay, I'm going to go into this and it might not be perfect, but like this is going to help.
Right.
Versus nothing we do has worked, nothing I'm going to try will work, and how that perception of what is going to happen can change that outcome for better or worse. And I see that Corwell is
Yeah, Gretchen has a question.
unmuted and have a hand up, so I'll try not to talk more.
Hi, yeah, so I have a question. I'm looking forward to digging into your resources regarding the sex-based differences. I do have some concerns, and so I'm just wondering, we know that in medicine, there are a lot of implicit biases against women, particularly women of color, and that their pain is often ignored and downplayed by providers, leading to delayed diagnosis of a whole host of medical conditions. And so in your reading of those studies and that literature, did they acknowledge that? Did they, recognize that in their own studies? I just kind of want to know a little bit more about that.
Yeah. So in the articles I read, there was no mention of race.
But specifically like sex-based differences, right? Like, I mean,
Correct.
even if we take
Yes.
race out of it, women versus men, we know that women's pain is often ignored and downplayed.
Yes. They didn't make specific mentions to that in the articles that I read.
Okay, thank you.
So yeah, then that would be like a valid critique of
Right.
those articles,
Articles,
right? Yeah. Mhm.
It'd be interesting to carry out the same studies in a different cultural context.
Right.
Yeah, for sure.
Yep.
Where there's maybe more of a matriarchal society or something of that sort, to
Mhm.
see what those differences are.
Exactly.
I'm curious about spiritual care and how you guys are using spiritual care down in Kalamazoo. One of our chaplains recently left us, but was palliative care certified and would gently remind us that I'm here for total pain too. And when the pain meds aren't working, try calling in the chaplain. And I know you had mentioned chaplain and spiritual care, so I'm just wondering what the role of the chaplain is that you've experienced, and how do they help with the total pain?
So I don't know if we have a designated chaplain for our team at Borges, but we do at Bronson. And so our chaplain at Bronson actually does a very good job at, sometimes he'll go in and see the patient beforehand and kind of give us an update on where the patient's at spiritually, so we can kind of address that. Aaron doesn't really talk too much about like pain, but he really tries to get a sense of where the patient is coming from, and that can help us as well. And he will go up and specifically the Christians, he will go up and pray with them if they ask that, and he is very good at finding people that share that spiritual belief and get them in that room to help with those patients as well. We brought him in to case number 2, but I don't feel that he made too much of a difference there because she didn't have a particular spiritual belief, but I've seen him do really good things and help people cope with their distress over their conditions. We had a couple people in one of the months I was there request him every day to come up and chat with them. And I think that did help their hospital course because they got discharged and we weren't sure they were going to get discharged. We thought they might die. So And yes, and at Borges too, all of us, especially in like our note template too, we have a section on spirituality. So we always make sure
To like prompt you
to
to.
prompt us
Yeah.
to discuss that too.
It's like
What do you say, Dr. Trexler?
Has that comment?
Hi, nice job, Alex. I did want to comment about the spiritual care aspect. Unfortunately, we don't have a dedicated chaplain, but we do interact with the hospital chaplains at Borges. And definitely the concept of spiritual pain. Anytime you have somebody with refractory pain, always think psychosocial, spiritual. And one resource that we do have is a neuropsychologist who deals mainly with the trauma patients, but he's also occasionally done inpatient consults for us in patients who are just having a really hard time coping with their pain, particularly if it's chronic pain. And so he can do some guided imagery and other cognitive behavioral therapies in the hospital.
I did not know that. I did not know that.
Any last final thoughts, comments? I know we're getting into the case study time.
I do have more comments.
Excellent conversation today, but maybe we can take some of those